data. So this is new data looking at some of the factors that we've thought are important in disability in transverse myelitis.
Thanks very much, Doug. Thank you. Good point. So many of the physicians who have been here have mentioned that they've been brought to this amazing community of patients and the TMA and the like through other patients. But in my particular case, I was brought to this community and to this illness by Doug, Dr. Kerr. And it really is to his credit that when he put together a team vis-a-vis what Steve Wagner was talking to us earlier about, that he enlisted my service and wanted a psychiatrist on board. Let me also tell you that on the topic of, so I work in the HIV psychiatry clinic and the hepatitis psychiatry clinic at Hopkins, and I do work on other neurological conditions that have psychiatric manifestations. And the reason why I bring that up is that almost always what the initial response is when I talk about depression and its as a comorbidity in these conditions, I get two initial responses. The first thing is from physicians usually, or often care providers, sometimes from the patients themselves. I'm told, well, the patients aren't depressed, they're stressed. And when I explain after examining the patient that they have changes in their sleep architecture, they've lost 30 pounds of weight, that family says this is not the person who we knew, and I tell the physicians that now this person is actually telling me that they are in the process of planning on killing themselves, often the response then is, well, okay, they're depressed, but wouldn't you be depressed if you had this condition as well? And that kind of reasoning, that two-step, those two steps, I think accounts a lot for why not enough attention is paid to psychiatric comorbidities in a lot of these chronic medical conditions. So what I'd like to do today is, for the first time to my knowledge, discuss the issue of depression and TM. So, you know, as far as I know, there's nothing published in the literature, and no one else has examined this comorbidity. And let me tell you something about it. And by way of telling you about it, what I'm going to do is first tell you something about what is depression, because if we're going to talk about it, we need to know what it is. Second thing I'm going to tell you is why does it matter? What's the importance of diagnosing a patient with depression? What's the significance for the patient and for society at large? And finally, then, I'm going to end and try to spend the most time on talking about what the results are in the transverse myelopathy clinic at Johns Hopkins. So let's get started. First of all, to discuss depression, I'm going to go back 2,400 years. And I'm going to go back 2,400 years in part to Hippocrates, in part to tell you that depression is probably the oldest, or certainly one of the oldest medical conditions that has been around in Western civilization. So Hippocrates, 2,400 years ago, first described melancholia, which was his term for it. There was the belief of the four humors of the body, and black bile was one of them. And so melancholia literally translates into black bile. And he described it as a state of aversion to food, despondency, sleeplessness, irritability, and restlessness. And let me tell you, to a first approximation, that's a very good description of the neurovegetative symptoms in depression. 2,400 years ago, this is the same condition we're talking about today. He went on to state that he believed this illness arose from the substrate of the somber melancholic temperament. This is before Mendel and his peas and the like, and he's talking about genetics here. He's anticipating that there's some innate predispositions in patients. He further went on, which, under the influence of the planet Saturn, perhaps a bit out there, made the spleen secrete black bile, which ultimately darkened the mood through its influence on the brain. Now, let me tell you, this is a very modern interpretation and synthesis of what depression is. Hippocrates, 2,400 years ago, is talking about serotonin and norepinephrine, okay, and its influence on the brain. Now, why do I bring this up? Because actually, for the first half of the 20th century, psychiatry, my field, has been trying to sell other people on the belief that what depression really is, for example, the ego getting frustrated, watching the id that wants you to sleep with your mother, battle it out with the superego. And if you think about that for half a second, I want to go back and explore the planet Saturn before I'm willing to buy that as an explanation. But this is, the reason why obviously I make fun of it, but the reason why it's not so funny is because the impact of psychiatry's representation of depression that way has been in a sense, to blame the patient who has depression and to say this is a character flaw. These people should be able to get it together and stop this battling between the different parts of their psyche. And really, Hippocrates had it right. He said this is a condition that affects the brain through this substance, which he didn't know what it was, but this is a brain-based illness. Okay? Now, let's talk about depression. What is it? Let's talk about it first. What is it in the general population so we can understand in transverse myelitis, we can interpret the findings. First of all, the current 30-day prevalence of depression in the National Comorbidity Survey, a big survey that went house to house, is 5%. 1 in 20 people suffer from depression in cross-section at any given time. The lifetime prevalence is 17%. Half as many men as women will have depression during the course of their life. And that's not just because it's harder to be a woman in our society, although it is harder to juggle the various things. The reason why I say that is that we know hormones have a lot to do with this. The big risk factors for women are in the postpartum period, perimenopausal period. There's also premenstrual dysphoric disorder, very much like depression, but follows the menstrual cycle. We know hormones are playing an important part of this aspect of it. And finally, the peak age of onset is 20 to 40 years old. Now look, anything that affects the brain can cause depression. And there's many people get idiopathic depression. It's, as I told you, it's a fairly common disorder, up to 20% of people. But if you look in neurology clinics, up to 50% of patients with strokes, up to 60% of patients with multiple sclerosis, Huntington's disease, Alzheimer's disease, and the like approach 50% of the patients. At some course during their life, they're going to have depression when they have these comorbidities. And again, any encephalopathic, toxic, or metabolic effect on the brain can cause depression. And the two that I'll just point out right now, first of all, interferon. I'm going to come back to this, but just to point it out now, interferon, what that does, we use this in the hepatitis clinic. It's a big boon to the treatment of hepatitis C. Interferon revs up the immune system. And it's important to think about when you rev up the immune system, we're seeing up to 40% incidence of depression. And in fact, the reason why psychiatry got involved in it at Hopkins is because the hepatologist came to us and said, our patients are committing suicide. We need you to come on board and help. And also corticosteroids have been associated with increasing the incidence. So is depression important? Why is it, should we even make a big deal of depression? And now I'm going to try to persuade you that depression is a very, very big deal. First of all, if you look at the 5 most common chronic medical conditions, hypertension, diabetes, coronary artery disease, arthritis, and pulmonary disease, and you look at its effect on daily functioning as measured by physical effects, social effects, role effects as father, mother, boss, number of bed days, and current health, gray means depression has more of a devastating impact on all of these aspects of functioning than the illness, and black means the illness has, the other illness, the chronic medical illness, has more of a devastating impact than depression. And as you can see, depression is currently the second leading cause of disability from chronic illness in our society. Okay? Second only to coronary artery disease in its impact. So it's impacting the patients. Next, depression is a lethal illness. Suicide is currently the 7th leading cause of death overall and the 3rd cause in young adults and adolescents who are less likely to be dying from diseases of old age. In the 15 to 24 age range, and we'll be talking about this with Dr. Karen Swartz, who's an expert on adolescent depression, this is a big issue. And the important thing to realize is that up to 86% of patients who commit suicide are motivated by depression. Up to 15% of patients with major depression will die by suicide. Those are the more severe cases, but that's still a phenomenally high mortality. We happen to have a Surgeon General right now who's paid attention to mental health care issues in a way that has never been paid attention to by the Surgeon General before. He declared war on suicide in 1999, and he said this: many people don't realize this. We turn on the television, we see someone was shot just down the block, someone we know was killed, and we think we live in such a violent society. Well, guess what? Many fail to realize that far more Americans die from suicide than from homicide. For every 2 people you read about who were killed in some homicidal kind of interaction, think that there were 3 people who committed suicide, and it wasn't reported. It was, the family hid their heads in shame and the like. This is a major public health issue. And then finally, there's just 2 other issues. There are a number of issues that I could bring up to tell you the impact of depression on people's lives and specifically on other comorbid illnesses they have. I'll take just 2 examples to show you the impact of depression. First of all, we have a tremendous amount of data looking at the role of depression and its effect on coronary artery disease. Depression following a myocardial infarction, a heart attack, is associated with a 3 to 4-fold increase in the risk of cardiac mortality, primarily as a result of cardiac death. This is not that they're killing themselves from suicide. This is not a 50% increase or a 100% increase. This is a 400% increase. This prognostic impact of depression is as large as and independent of other major prognostic factors, including tobacco use, left ventricular dysfunction, severity of coronary atherosclerosis, and history of a previous MI. Depression is the most significant predictor of, is this patient going to die from cardiac reasons? Depression appears to be cardiotoxic is the take-home message from this. And patients have been studied, and there's a change in their heart rate variability, their ability of their heart to respond to what's going on. But to not ask about depression in a patient who's had a myocardial infarction is like not asking him if he smokes, something you can intervene and stop, not taking an EKG, not finding out if that patient's going to be a candidate for a cabbage. You can't see this if you're beyond the front row. But let me tell you, I just added this last night because it occurred to me that in this particular context it's important to note. There was a study done just within the last year that showed that there's a 20% hippocampal volume loss in depression. Depression doesn't just affect the heart, it is a brain-based illness, but the important thing to know is that anything that affects the brain can cause depression. But it's further complicated because depression can affect the brain. These researchers looked at hippocampal volume, and they showed that here the mean volume in comparison subjects was 1,200 millimeters squared, and in patients with depression it was 940. That's a 20% decrease. It was specific, and none of the other regions that they studied, including the whole brain, showed the same kind of decrease in the size. And also there's evidence, and this is one of the projects I'm working on in the lab, there's evidence that antidepressants induce growth factors in the hippocampus, and that perhaps one of the ways that they're working is to correct the neurotoxic effects of depression. But you see, you can very easily construct a model. I'm going beyond what our data actually supports, but if neurological insults can induce depression and depression can induce neurological insults, you can see very quickly how you could get into a positive feedback loop. So now let's talk about depression. What is depression? Well, first of all, MDD does not stand for man in a deep depression, but I bring this up because a lot of the problem with the concept of depression is that it sort of leads people to the assumption that it's a dip in the road, that people get stuck in a dip in the road, and all they have to do is stand up to get out of it. And depression is a very vague term, so let's talk about what is major depression. First of all, depression is vague because it can refer to an affect, which means someone's range of emotional response. Some people, you tell them a little joke and they crack up in hysterics and they're crying, they think it's so funny. Other people, they give you a little And that's just a range in terms of people's normal emotional response. That's an artifact of temperament. Second of all, depression can refer to someone's mood, and by that what I mean is just sadness. You're not aware of what's going on in your life or in the world if you haven't experienced some sadness, okay? And finally, what we really want to differentiate these from is melancholia, what Hippocrates was talking about 2,400 years ago. So let's deal with the first artifact of temperament. Here, the doctor's talking to his patient. He says, I'm truly concerned a person in good health would have laughed at my Clinton jokes. Okay? Now, the reason why I put this in is at Hopkins, roughly 5% of the consults we get on the psychiatry service for inpatients on medicine, of course not neurology, but surgery and other areas, 5% of the consults we get go like this. Can you please come see this patient? Mrs. Smith is depressed. How do you know she's depressed? You could just look at her and see she's depressed. Well, did you ask her, is she sad? Does she have problems with her sleep, appetite, etc.? They say, oh, well, no, but you can look at her and she's depressed. You go talk to Mrs. Smith, she'll say, I'm worried, but this is, I'm always like this. I'm not a very exuberant person. So you gotta, go farther than just, sort of the man on the fast horse making the diagnosis. That's not what it's about. So what depression is not? Depression is not normal sadness. It is what sadness is an intermittent universal experience. Depression with a small d, it is a symptom. The degree and duration is appropriate to the stressor. It is unaccompanied by either severe or persistent psychological symptoms. If you're hearing voices or you're unable to concentrate or focus, you can't even watch you keep reading the same page over and over. You can't even watch 15 minutes of the news and retain anything. Severe cognitive impairments, that's not from sadness, that's from depression. Finally, it's responsive to the environment. Good news buoys your spirits. It doesn't unduly disrupt work or social function. And obviously, there are exceptions to that. You can have very severe sadness where it does. Major depression, in contrast, is a syndrome. It is not just severe sadness. Sadness is to major depression what cough is to pneumonia. Cough, now using this analogy, cough can be an indicator of pneumonia, but not every cough is as a result of pneumonia, and not every sadness is the result of depression. Sometimes pneumonia presents without a cough, and particularly in the young and the old. Same is true with depression. Particularly in the young and old, you can have depression without sadness. Consider the company the cough keeps. If the cough is accompanied by productive sputum, tachypnea, fever, and consolidation, which means that people are coughing up a lung, they're breathing fast, they have temperature or an area of an infiltrate, a fluid collection in their lung, that we call the syndrome of pneumonia. So let's talk about the syndrome of depression. First of all, what are the core features? Well, it does involve morbid sadness, persistently low, and unresponsive mood. That's the key. I treated a dot-com millionaire, a 24-year-old, $100 million he'd made at the age of 24. And he came in to see me. I said, what troubles you the most? He said, the thing that troubles me the most is no one will listen to my complaints. I am miserable. I am not sleeping. I'm losing weight. And no one takes me seriously because they all say, you got $100 million. What do you have to be sad about? That is one of the hallmarks, okay? Unresponsiveness of his mood. Good things happen, still depressed. Bad things happen, maybe even more depressed. Diminished self-attitude, another core feature. Excessive low self-esteem, self-criticism, self-doubt, and guilt. Change in vital sense. There is a neurophysiological change in patients with depression. We can study their sleep architecture. REM sleep is earlier in the night. Food doesn't elicit the same response in terms of stimulating appetite and the like. That's why patients often lose weight. Subjectively diminished mental and physical energy, diminished sense of somatic well-being, and accompanied by neurophysiological derangements. And you can get a sense here, the diminished sense of somatic well-being, how you can get into trouble, because as you get depressed, everything seems worse. You have a little bit of pain, you get a little depressed, and that pain now gets worse. That makes your depression worse. Now you're getting into a positive feedback loop. Just like when you're sleep deprived, the pain gets worse. Imagine it 100 times worse with depression. So this is what the DSM, not the end-all and be-all in the diagnosis, but I think the simplest way to use it in the clinic and perhaps when assessing loved ones. The DSM-4 criteria, the sort of the handbook of psychiatry, talks about 9 symptoms, and the acronym is SIG-EM-CAPS: decreased or increased sleep, loss of interest or pleasure, guilt or feelings of worthlessness, low energy or fatigue, as was brought up. Obviously, you want to make sure that chronic fatigue isn't part of an underlying depressive condition. Low mood, impaired concentration, increased or decreased appetite, feeling slowed down, what we call psychomotor retardation, people who just drag along, and suicidal ideations or thoughts of death. You need either interest or mood as one of the symptoms, and then you need 5 of 9 of those symptoms for greater than 2 weeks. The more symptoms you have, the more likely you are to respond to antidepressants. Important points to remember in diagnosing depression as we close about sort of what is depression. There's a powerful temptation for both patient and care providers to ascribe internal mood states to external events, as I talked about the 2-step at the beginning. There is no mention of in the criteria of major depression of life circumstances or comorbid medical or neurological diseases. Nothing says, oh, and by the way, if the patient has TM, they don't have depression. Okay? There's nothing in that criteria. And in fact, adverse life circumstances and illness are not only not protective, but in fact they are associated with increased risk of depression. If you have MS, you've got a significantly increased risk of getting depression. Not only is it not protective, it's likely to be exacerbating depression. Do not confuse associations with causation. I think that point is made. And finally, for the physicians, if you know the patient, you'll know if they're depressed. That's not the same person you know. If the patient's coming to you, and the patients, and particularly the loved ones and family members of patients can tell you, anybody who's been with a friend or family member who's had depression, that the outside informants, meaning the family or friends, can be invaluable in making the diagnosis because they always know that something is up, that this is not the same person. This is not a quantitative change, it's a qualitative change. And this is sort of exemplified here. We've got Clark Kent and Lois Lane sitting here. It says, after many years of marital bliss, tension enters the Kent household and she's embroidering stupid on the... Now, look, I can't tell you if it's that Clark Kent is now depressed and he doesn't want to put on the cape and go save anybody, or whether Lois Lane, being depressed, becomes disenchanted with the man she married. But I can tell you that they will know. Okay? If you ask the one and the other, they'll tell you. Finally, one last point in the diagnosis. The differential diagnosis of depression involves sadness, grief, and demoralization, as we talked about. And also, you got to rule out delirium. First of all, this is an overlapping Venn diagram, and in fact, it should show, probably the majority of patients with depression have demoralization as part of it, but also delirium. If patients are delirious, we're not talking about depression. Patients who have pneumonias or are hypoxic or these kinds of things, this is very often dysphoric, and that's not usually depression. So now let's use MS, because as I told you, nothing has ever been looked at in terms of transverse myelitis. So before we can understand transverse myelitis, let's look at the closest cousin for which there is research, and that is multiple sclerosis, another idiopathic demyelinating illness. And let's see if there's any lessons to be learned from MS patients. The lifetime prevalence, as I told you earlier, of depression in MS patients from the various studies that have been done is 37 to 62%. That's in comparison, that's fourfold, threefold higher than in the general population. The current prevalence is 15 to 30%, which again is about up to a six-fold increase in the general population. MS predisposes people to depression. What is the impact of depression on the MS patients? I've just listed a few highlights here. There are a number of studies that have been shown you treat the depression, you improve the rehabilitation. Often patients are referred to me because they were going along on their rehabilitation, doing better and better, and suddenly they fell off their curve, and now they've just stopped. You treat the depression, they get back on the curve. It also affects quality of life and function. In other ways, association between cognitive dysfunction and depression. Cognitive dysfunction in MS is a big problem for these patients, and there's been a number of studies showing a link between cognitive dysfunction and depression in these patients. And this is a very important point. The rate of suicide is up to 14-fold greater in MS patients than it is in the general population. This is a lethal illness, as I've told you, and to omit a recognition of depression is to allow the patients to go on and potentially die from something which is, as they say, smoking is the most treatable, illness, cause of death in this country. Well, let me tell you, this is perhaps the most treatable cause of death in these patients. Depression can be treated. You can expect 100% recovery in the patients who are recognized and treated. At least that's the target. Evidence now, look, now I want to present evidence for an etiological link between the pathophysiology of MS and depression. I've told you insults to the brain cause depression. Let me show you what the evidence is here. First of all, if you were to say that maybe that the MS patients are just stressed, okay, remember the diagnostic two-step, then you just say, well, maybe we know there's a genetics to idiopathic depression, that maybe if these patients are just stressed, you'd expect them to have idiopathic depression. And idiopathic depression, patients would have relatives who also would have depression. It has the same heritability as hypertension and hypercholesterolemia. That's what idiopathic depression has. On the other hand, if it's due to the insults of the MS, they didn't have any association with family members because what happened to them is MS. And that's what the target is. And what we find, as you might imagine, is patients with depression with no MS, idiopathic depression, have 6.4% of their first-degree relatives have depression. MS patients without depression have 1.5% of their first-degree relatives, and that's, again, because it doesn't run in their families like it does in patients with idiopathic depression. But MS patients with depression have no greater increase. It's not because they're vulnerable people who have the genetics for depression. It's more likely to be the insults of the inflammatory process in the brain. Now, further evidence, there is an association which has been consistently found, not in all the studies, but in the majority of studies, between depression and the course of the illness with MS. Depressive symptoms increase during periods of exacerbations, and the rate of suicide also increases during periods of exacerbations. There is no association that has been found between physical disability and depressive symptoms or depressive syndromes in these patients. That's an important thing to consider, because we always want to write off, well, you'd be depressed too if you had trouble walking or with your bowel or bladder. There's no association in MS. Okay? But there is an association. It's more common in patients with cerebral involvement than those with predominantly spinal or cerebellar forms of MS. Obviously, we'll come back to this in TM. And the MRI correlates of depression in MS are that there's greater periventricular pathology and greater total area of temporal lobe involvement, suggesting that there are even perhaps specific insults to the brain that predispose to depression. And this role of cerebral insults in generating depression is already established in post-stroke depression, where we know that this particular region of the brain that's affected seems to play as much a role or more role than the level of disability. Patients can have a left frontal stroke, minimal disability, no effect on their sensory, motor, or autonomic function, and terrible depression. Finally, there is an association of corticosteroid exposure and depression in MS, supported by two cross-sectional studies, not supported by one case control study, but there is a suggestion that corticosteroids may predispose to depression in these patients. So finally, just to summarize, what can we learn from MS? Depression is common in patients with MS, and it's associated with considerable morbidity and mortality. The available evidence suggests that depression in MS is caused by the effects of inflammatory insults to the brain. There may be an association between steroids use, although it's not rock solid. So based on this, what might we hypothesize before we turn to now discuss what the results are in the transverse myelopathy clinic at Hopkins? Well, we might hypothesize that since, unlike MS, TM by definition affects only the spinal cord and not the brain, that the rate of depressive symptoms would be lower in TM than MS, and that the depressive symptoms might only correlate with the degree of disability, because maybe this isn't major depression. Maybe these people are just stressed, these people being in the room. I should tell you, I give this same talk often when I go to visit primary care practitioners. Like MS, the other possible hypothesis is like MS, transverse myelitis is an inflammatory process affecting the central nervous system. And, I'll talk more about this later, but we found that all you have to do is plasmapheresis, and you can, improve the people. That has nothing to do with affecting the specific site necessarily. That may be causing a general effect. And as I told you before, interferon, which revs up the immune system, and arguably TM and MS are examples of revving up the immune system, pathologically revving it up, are associated with an increased incidence of depression. So we still, though, would predict that TM would be lower in the patient, depression would be lower in the patients with TM than in MS patients, perhaps because there's more insults in MS. It affects all over the neuroaxis, multiple sites, multiphasic, multifocal. So we would still predict a lower incidence, but we would say that the depressive symptoms would not be expected in this case to correlate with disability. Well, guess what? We found neither of these. I'm just telling you what we looked at ahead of time to show you what our thinking was, and neither of these is what we found. So what did we find? First of all, how did we do it? Doug came to me and said, we've got to look at depression in these patients. Being the kind of physician who doesn't forget that the brain is an organ. It's Woody Allen's second favorite organ, but it's an organ that affects many things. And in addition to affecting your motor, sensory, and autonomic system, it also affects things like mood. So what we did was we gave a questionnaire, which I'll show you in the next slide. Many of you may have taken this. Anybody who came after the date we started handing these out to all of the patients seen consecutively in the clinic received this SCL90 screening test. And so this is the data I'm going to show you on everybody we had up until, this is as of a week ago. Everybody that we had, there were 26 patients with MS, 74 patients with TM. And the age was not significantly different. It was essentially identical. The sex was different, though. For some reason, Doug is a magnet for women with MS. And so the 84% of the patients, this is just random variation, 84% of the patients he saw who had MS were women, as opposed to 60% of the patients with TM. That was statistically significant. So bear in mind that we would predict based on this, since I told you depression in the idiopathic depression in the general population is twice as common in women, we would expect the MS patients, therefore, to be manifesting an increased rate of depression relative to the TM patients based on that fact alone. In other words, if we're just looking at an idiopathic effect, we would expect MS to be loaded for depression based on this difference. And we'll show you what we found. Lastly, compare the motor disability of these patients. It was identical. Okay? So we didn't assess all disabilities, motor, sensory, autonomic disabilities, and that needs to be done. But we did look at motor disability in the MS patients. We looked at all disability in the TM patients, and the motor disability was not different at all. Okay, so you can't say, well, it's because those patients were not able to walk and what have you. So this is the symptom SCL-90 checklist. It's 90 questions. You can complete it in 10 minutes. You rate it 0 to 4 for the various symptoms. And it's been standardized against 1,000 quote-unquote normal people, which just means consecutive people in the community who were selected for not having depression or other major psychiatric comorbidity, and it's normalized against them. And it assesses 9 subscales. Somatization, which is perceptions of distress from body complaints, obsessive-compulsive, ruminating thoughts and impulses to do things, interpersonal sensitivity, which is feelings of inferiority and inadequacy, depression, which is the key one I'm going to talk about today, anxiety, hostility, phobias, paranoia or suspiciousness, and psychoticism, which is both psychotic hallucinations and delusions, as well as an indicator of withdrawal. So what did we actually find? And this was what was shocking to me. First of all, this is just showing you this is the normalized population, and this test doesn't diagnose depression. I need to be clear on that, okay? This test diagnoses the burden of depressive symptoms, that the more symptoms you have, the more likely you are to correlate with having depression, but no subscale. You can't just send someone home with a test and, prescribe them an antidepressant in the mail. You've got to have them come in and do a comprehensive evaluation and rule out other things. But the more burden of, the higher your scores on depression, the more likely you are to have it. And at the extremes, those patients are at dramatically high risk. So what did we see? Well, this is just, again, showing you one standard deviation in the normal population would be 14% of the patient would then, as we're defining it on this score, on this test, have mild to moderate depression. Only 2%, patients in the 98th percentile for their depressive symptoms, we call severe. First of all, MS had about 1/3 of patients who had the mild to moderate level in their depressant scores, and 8% of the MS patients had severe depression scores, which was they were in the 98th percentile for their depression suffering, depression scores. What was shocking to me is, and that led to a total of 40% of MS patients were at risk. Okay, we're at significant risk for depression, particularly this 8%. What was shocking to me is that 50% of the patients with TM were at risk, and that was not statistically significant, the 40 to 50%. But what was statistically significant was, as I told you, the more important finding, which is that the 98th percentile suffering was found in 16% of TM patients and only 8% of MS patients. That had a statistical significance of 0.05. Now, what is it that were the specific symptoms that were endorsed by these patients on this test? Let me tell you, the most common one was feeling blue or sad, okay? Also, worrying excessively, feeling hopeless, everything was an effort, feeling worthless, low energy, which we might ascribe that as a confounder to the effects of the TM. Decreased libido, again, might be effect of the TM on sexual function. But look at this. This, to me, is the most frightening. The smallest bar on here is the most frightening one on the whole bunch. And let me tell you what this is. SI, the question was, how bothered are you by thoughts of wanting to end your life? This is suicidal thoughts. How bothered are you? And in patients who scored greater than 60, which was 50%, remember I told you 50% scored in one standard deviation greater than the norm, and 60 on this test corresponds to that 50%. About 25% of TM patients said that they were troubled by thoughts of wanting to end their life, commit suicide. That is very frightening. Now look, I told myself I wasn't going to do that, but I did it. So I want to actually take a poll, because now we're going to do an experiment. You are all participating in an experiment, and it will be very informative to me if you actually raise your hands when I ask you the following question. And I'm just going to break it up to everybody. So TM causes 3 main sources of disability: motor, sensory, and autonomic. Autonomic being urinary incontinence, bowel bladder incontinence, and sexual dysfunction. And Doug and Chitra in the clinic came up with a screening questionnaire to look at these disabilities. Now let me ask, just for a raise of hands, who thinks that the depression and the measures of psychological distress in patients with TM correlated most? Because I will tell you, it did correlate to some extent, modestly, with one of those three motor, sensory, or autonomic nervous system. So how many patients or care providers or people who are just decided to come in today, how many people think it's motor disability correlated? Okay, so I perhaps said earlier, as was raised as a point, motor actually had no correlation whatsoever with level of psychological distress. And that was surprising to me. I mean, none. It was the least likely to correlate. So, you know, and Dr. Kerr, who has seen more patients than anyone I know with TM, told me that that would be the case. He said people adapt and they get on with their functioning. How many people think it's sensory, as sensory being complaints of pain, paresthesias, although actually pain wasn't one of the questions, but people might have responded to pain, but paresthesias, numbness, feeling of tingling, and the like. How many people think sensory symptoms were? Okay, how many people think bowel or bladder incontinence and sexual dysfunction? And that's very interesting. See, I'm very glad I did this study, because I would have raised my hand there. But let me show you what actually you showed me, the people who took this test. There's no association with sexual function, okay? This is greater levels of being bothered on the disability scores. So these patients are vent dependent if they have a motor, for motor disability, 5 is that. Sorry, for sexual dysfunction, that corresponds to the highest level of disability. And you see there's no correlation. It goes down and up and down and up. There's no correlation. Also, with bladder dysfunction and incontinence and the need to use urinary catheterization, it goes down and then up. No correlation. Same thing is true with motor disability. And you see the P-score here is 0.956. Absolutely random association there, none whatsoever. But hiding in the back in red is sensory disability. And as you go up in your reports, the scale was 0 to 3, and as you go up in that, you get an association. And that association was 0.013. That is statistically significant, the correlation. Now, I can't tell you, by the way, if it's that patients who are depressed are more likely to be endorsing or reporting that they're bothered by those symptoms, or if it's that the sensory symptoms cause the reports of the low mood. It just, there's a correlation, and I can't give you causation. But what I can tell you is that 7 of the 9 subscales on the SEL90 had a significant correlation with the sensory disability. And none of the subscales, 0 of them, correlated with motor dysfunction or the other dysfunctions. There was no significant. There were some, but they didn't reach statistical significance. But sensory was significant on 7 of the 9 subscales. It accounted for 14% of the variance in depression, which didn't account for 50% of the depression or 75% of the depression, meaning the variance being how far people deviated from the line that would be generated from the more sensory disability to the more depression. But 14% was statistically significant, and these are the symptoms that were assessed on the questionnaire: burning, prickling, tingling, electric, feelings of dead feeling or numbness. And that to me was very interesting. Now, as I told you, we cross-correlated all of the things in the database. And that included white blood cell count in the CSF, oligoclonal banding, spinal level, where the spinal involvement was. And we looked at acute presentations, acute motor disability versus convalescent motor disability, acute sensory versus convalescent, same thing for sexual dysfunction. And we cross-correlated all of those variables, every single one of them. None of them had dramatically statistically, in fact, none of them had any statistical association with depression, except one, and that one is going to be a little controversial, but I do want to present it because this is the data. And that one ended up to be, if you reported being treated with IV steroids, you had a 70% increase in your depressive scores on this test. That doesn't mean you had depression, but there was a 70% increase in your scores of depression on this test. And that's shown here. The average score, average, which means 50% were more, 15% were less. Average score, if you hadn't received steroids, was 50, which corresponds to the 50th percentile of the general population. Your average score, average now, okay, 50% more, 50% less, was 61 if you'd been treated with IV steroids. That was significant to the .006 level, and that corresponds to the 85th percentile. So you went from 50th to 85th percentile in terms of your depressive symptoms. And just to show you, this is true, that the average acute motor disability that patients reported having at the time that their diagnosis was made was not different whether you received IV steroids or didn't. Because you might say, well, maybe the less severe cases received no steroids, and only the severe cases received steroid. At least the data doesn't support that. This is, I've shown you the motor. That's also true for sensory. Subjective reports of how your sensory disability and motor disability was at the time of the diagnosis was not different between these groups, but boy, the depressive scores sure were. So what are the conclusions? Let me tell you what I think I can say confidently based on this. First of all, depressive symptoms occur at a markedly high rate in transverse myelitis that is even greater than in control populations of MS patients in this clinic. Depressive symptoms did not correlate with the degree of motor or autonomic disability, spinal level, or biological markers of the disease. All of the correlations were negative with depression. There was a correlation between sensory disability and depressive symptoms that accounted for 14% of the variance, and I think, as was brought up earlier, should suggest to the physicians that you need to pay very close attention to those symptoms in these patients. And again, perhaps it's interesting to note that if you're troubled by those sensory symptoms more than you are troubled by problems with ambulating, as was raised earlier, you're not alone. This is what you guys who have taken this test are telling us. Treatment with IV steroids did correlate with a significantly increased rate of depressive symptoms. So now I'm going to interpret these findings for you. I can't tell you that this is for sure the case, but let me tell you what my interpretations are. This is open to other interpretations, and we can talk at a later date about what those are. First of all, sensory deficits, this is just what we talked about, cause the greatest degree of psychological, emotional suffering, or patients who are depressed specifically are bothered by sensory symptoms more than they are. I can't tell you cause and effect. Possible reasons for a dramatic prevalence of depression in TM, which is even greater than MS, well, it could be that the magnitude of sensory disabilities in our patients with TM exceeded those they had in the patients with MS. They had the same motor disabilities, but maybe, since we didn't measure it, the sensory disabilities were greater. We need to do further follow-up. This is preliminary evidence. But I also want to raise the possibility that depression is a marker for brain involvement in TM. And this is a remarkable thing I'm suggesting. I'm saying depression is one of the responses that the brain has when things go wrong. Seizures, by the way, are another response. People used to think you were possessed if you had seizures. We now know that's the brain misfiring. Well, people used to think that you were just weak if you had depression, and we now know that that is the brain misfiring as well. And I'm suggesting the possibility that this is a marker for TM, although you clinically see an effect in the spinal cord. There may be a broader effect, and we've learned about a lot of the cytokines that are upregulated in these idiopathic inflammatory processes. We know that if you just sieve the plasma, that you can affect changes in these conditions. So I'm suggesting depression may be a marker for higher cortical cerebral brain involvement in TM as part of the neuroimmunal response. And finally, perhaps most controversial, TM patients treated with IV steroids may be at significantly increased risk for developing depression. So let's talk about future directions. Increased surveillance needs to be done for patients with TM for looking for major depression. Longitudinal follow-up is what we're planning to see how depression affects long-term mortality, morbidity, and outcomes, to compare sensory disability in TM with that of MS, to screen TM patients for cognitive changes, which again would suggest that TM is affecting higher cerebral functions. And there's a need, I'm just going to say this, since we don't have any controlled trials to suggest that steroids make any difference I'm just telling you the data in the outcome of patients. Now that may be that there are a few patients who have a dramatic response to steroids and the majority don't, and that would be screened out. But so far we have no evidence to suggest that steroids improve outcome. And what I will say, though, is that anybody treated with steroids, just like anybody who has a heart attack, you are remiss if you don't screen that person, or if you yourself know of someone who's treated with steroids. I think you are remiss, based on the data we have, which is preliminary, if you don't screen that person for depression. And this is the most frightening slide I have here. Let me tell you, in the Transverse Myelitis Clinic, we've seen, and I use we very loosely here, I really mean Doug's seen, 200 patients, okay? 2 out of the 200 have committed suicide. That is in 2 years. That is a suicide rate of 1 in 100 patients per year. That is a small sample, but I'll just line it up for you. Based on the information we have right now, the suicide rate in the general population is 12 in 100,000. In MS, it's 14-fold higher, 168 in 100,000. And right now, we have data to suggest it is almost 100-fold greater in TM. This is something you don't want to miss. It's treatable. And just to remind me to say it, of course your daddy loves you. He's on Zoloft. He loves everybody, okay? This is a condition that the expectation is for 100% recovery. Any patient who comes into my clinic, the goal is 100% remission, 100% long-term remission. We don't always get that, but that's what the goal is. And finally, before I sum up, and I've sort of got the stop, can I just have another minute just to finish? So just one thing that Cody Unser mentioned last night, wise beyond her years, I just want to say a word about. Last night she mentioned that when she went to the emergency room, the first thing the somatic doctor, the doctor who takes care of complaints of the body, told her when she came with these physical symptoms was, "It's all in your head." And now I want to be careful that I, as a psychiatrist, do not send the message that all of your suffering is in your body, the brain being part of the body, okay? Let me just stress that, as was very eloquently detailed by Dick at the very beginning, this is a journey of, in part, learning to overcome the demoralization and isolation that comes from having a diagnosis that it's very tough to find anybody who's heard anything about, of adjusting to life under all sorts of circumstances. And so I just want to make sure I communicate that that demoralization and depression are different things. And we're talking about a small percentage of patients who are at significant risk for having depression, and you need to treat that depression, but it doesn't mean that if you've had suffering, you have depression, and nor does it mean that just because you've suffered and not had depression, that your suffering was any less than someone who had depression. Because in essence, beyond a certain range of threshold, all suffering is non-quantifiable. And I've just written down a quote here. William Wordsworth said, "Suffering is permanent, obscure, and dark, and shares the nature of infinity." And half of infinity is still infinity. And the point I'm just trying to make is that it is important, and I'm trying to drive home the importance of screening for depression, but it's going to affect a certain and finite percentage of patients, whereas suffering affects everybody. And learning to overcome it, as Cody Unser so eloquently detailed, and Dick as well, and other people here have detailed, is part of the process of overcoming this illness. So I don't want to overstress or overshoot my bounds. Finally, I just want to thank all of the patients, because if the patients don't complete the questionnaires and participate, we get lousy data. So we had 95% response rates on these tests. So thank you to the patients, to Dr. Kerr, who combines for me the best I've seen in terms of clinical patient care and research. And he gets the fourth arm that we don't talk about at Hopkins. He's a good human being, and I consider myself lucky to call him a friend. Finally, thank you to Chitra for all her work on the disability scores, Dave Edwin and Karen Swartz, who's here, for their help on data analysis, and Eun-Kyung Choi, who was an undergraduate, who had the wonderful time this summer of writing all 90 responses for all 100 patients and pulling all their charts. Thank you very much. Okay, pizza's here. So we're spreading it out.
And